for this clinical month meeting. So we are going to have presentations from the Department of Endocrinology as well as from the Department of Neonatology. So over to Dr. Krishna for his presentation on newer drugs on diabesity.
So thank you, sir, for the introduction, Logan sir, and I thank the management and director for the opportunity. So today's topic will be complex diabetes. So yesterday, sir asked Logan sir, "What is complex diabetes?" I said, "Just we can name whatever we want." So if you don't know how to manage it, we can name whatever we want. And we can name as complex. And diabesity is of course now it's a proper word coined where you couple with obesity and diabetes, and there may be a connection between both of these. The patient has got a difficult challenging diabetes because of obesity, and vice versa too. Because of the diabetes or its management, the patient still has got the obesity, increasing obesity and its complications, and insulin resistance. So again, this word is going on among non-medical group. That is, we can just divide the whole of country into two groups. One is medicos and the rest of non-medicos. So this word is going enormously. Insulin resistance, sir, I have insulin resistance, I have insulin resistance, as though insulin resistance is a separate entity. It is not a separate disease. Most of us here have insulin resistance. So insulin resistance coupled with insulin deficiency is called as type 2 diabetes. That's all, very simple. So you need a biochemical glucose elevation along with insulin resistance to get type 2 diabetes. If there is no insulin resistance, only biochemical deficiency, that is for type 1 diabetes. That's all. We can keep it very simple. So increasing insulin resistance, there are various things, various reasons, particularly in Indian race. A lot of theories have been put forward, lot of theories have been proved, particularly excessive 11 beta HSD enzyme activity. To put it simple, excess cortisol activity in Indians. So subclinical hypercortisolism for most of the Indians. So that's why we got that pot belly appearance. The only race among the whole earth we have is pot belly. Because of that causes insulin resistance is one of the theories put forward. So this is actually a highly challenging in type 2 diabetes. Very difficult in type 2 diabetes, particularly in adults. Commonly in middle-aged adults, middle-aged 40 to 50s, either gender. We see this day to day. The numbers are increasing. We put give lots and lots of insulin. Even if they are on diet, it's becoming very difficult to manage all these patients. So one more thing is, another common association is obstructive sleep apnea along these patients. So I'm not covering it here, just to put a point. So literally, I am seeing more of OSA cases more than Department of Pulmonology for the past, say, 2 to 3 years. Daily, I'm seeing around 5 to 10 patients, but it's very difficult to convince them. Do a sleep study, go to the pulmonologist, becoming very difficult for me because they themselves read a lot in internet. They put the diagnosis of insulin resistance. They do the test. They themselves start on metformin, thinking insulin resistance, metformin can tackle insulin resistance. So a few cases we'll see it here. So before that, HbA1c targets. So again, we being a tertiary center, this HbA1c target we see often doctors having a fixed target of 7. We should bring it to less than 6.5. We should bring it to less than 6. Never above 7. Always above 7. 6.5, 6. Particularly in the field of reproductive endocrinology, they say go to 5.5 to 6. So it's not like that. It's highly variable. So we cannot expect 85-year-old to run a marathon, although they are running actually nowadays. So we cannot expect a stroke patient to run for 200 meters. We expect them only to walk. That's all. So highly variable targets for each, highly personalized, customized targets for each and every patient should be there. Long-standing uncontrolled diabetes, say 23 years of diabetes, 33 years of diabetes, 47 years of diabetes. So with retinopathy, with nephropathy, history of stroke, patients got a foot ulcer, HbA1c, relaxed HbA1c targets, less than 8, 8.5 will suffice for them. So because most of them will go for hypoglycemia, silent myocardial infarctions due to hypoglycemia, they may call VTVF. So all these things happen, falls, lot of things are there, not just mere number. So for these patients, just giving treatment without hypoglycemia, we achieve less than 200, 220 sugars, it's fine for them. There is no difference for them for a HbA1c of 7 or 7.9, 6.5, 8.1, there is no difference for them. Patient comes with a diabetic foot ulcer, we randomly keep it below 220, that's all, for the wound to heal. So strictly we not give it to 110, 120, 130 sugar, that is not required, that is very difficult to achieve, that will cause more harm to the patient. So in general, try to bring the HbA1c less than 7.5 as much as possible. There is a holistic approach, that's all. So based on treatment, the HbA1c control also is based on treatment also. So it's not just a mere number. So what is the proportion, intensity of treatment the patient is going on? Just diet alone, or OADs, oral antidiabetic agents alone, plus insulin alone, plus insulin. So stricter targets can be easily achieved for individuals who are just on diet, only on diet. So again, we see a lot of patients with pre-diabetes started on metformin. Of course, everywhere, say anybody can treat diabetes, everywhere throughout the country, they start on metformin for pre-diabetes. It's very, very difficult for the patient to lose weight if you start metformin. Contrary to the thought, metformin makes you to lose weight. No, it also, the first work of metformin, it is a diabetes drug. Remember, it's not a weight loss drug, it's a diabetes drug. It will cause hypoglycemia. For a pre-diabetes patient, if you give metformin exactly 11:30, 12 o'clock, they will go for hypoglycemia. Not severe hypoglycemia, mild hypoglycemia. So what happens? Defensive eating, the weight increases, once again the sugar starts climbing. So for pre-diabetes, just leave them alone, give dieting, that's all. So and follow up, of course follow up, because 50% of pre-diabetes will enter into diabetes. That is, again, diabetes mellitus is not preventable. Remember that diabetes mellitus is not preventable. It can only treated. Complications are preventable. So relax targets for patients on insulin and multiple OADs, 4 drugs, 3 drugs, 5 drugs, and insulins twice daily, thrice daily, once daily. So many varieties are there. For them, relax targets, HbA1c of less than 8 will suffice without hypoglycemia, not even one episode of hypoglycemia. So achieving a target of the statistical number of 6.5. So that number is a statistical number, statistical mean for diagnosis of diabetes. It is not a target as given in the side values of the lab report. So most of the patients read the side values. We are also seeing medical practitioners seeing the side values. That is for just for a reading purpose to diagnose diabetes. So you need not achieve of less than 6.5 for all individuals. So that is for individuals only without diabetes. So for less than 5.7, no diabetes for diagnosis, 5.7 to 6.5 pre-diabetes, more than 6.5 diagnosis of diabetes. Again, more than 6.5 individual comes, 6.5 to 8, lot of muscle checkup patients come. I have 7.2, extremely high sugar. So what happens? They go into a shock when they say no drugs needed. So their random sugar is 133 only or 180. If I give drugs, they'll go into hypoglycemia. So most important is the last point for us as a tertiary center. So less than 8.5 in comorbid conditions. Most of our patients, we are in a tertiary center, all of the departments have comorbid condition only. Neurosurgery, neurology, oncology particularly, nephrology, pulmonology, medicine, any department. Achieving HbA1c of 8.5 is more than enough. All the random sugars should be less than 220. That's all. Even if you are taking up, most important, taking up of surgery. So that day sugar, many times we see that day sugar, if it's 450, there's a tendency, it's a greater tendency for all the surgeons as well as the department anesthesia to postpone the case. There is no need to postpone the case. That 450 can be brought down by the so-called magic drug called as insulin, because there is no upper limit of insulin. You can give load 100 units and bring down the sugar. There is no issue. You can take up the case, because we are in a tertiary center. We cannot keep on postponing cases. So all the cases come to us not straightforward. So they have been to so many places. Eventually we cannot postpone the surgery. So take up the case. Then thereafter, every day keep on monitoring, bring down the glucose and maintain the glucose throughout life. So that is the most important point. Of course, it changes the outcomes. See, a malignancy, we can, or a procedure, important procedure, renal procedure, whatever, we cannot wait for 3 months for the HbA1c to come to 8. So we have to take up the case. So it can be brought down using insulin. So drugs in diabetes, in a nutshell: sulfonylureas, glimepiride, glibenclamide, gliclazide, all these you would have heard, and by currently using metformin. There is only one drug in that class, and SGLT inhibitors. Sorry for the spelling. It's remogliflozin and dapagliflozin and empagliflozin. So most of you would have heard of dapagliflozin and empagliflozin. being used in all departments, particularly in cardiology, neurology, medicine, as a weight loss drug, as a renoprotective drug, etc. And of course, it is a diabetes agent. So DPP-4 inhibitors, linagliptin, sitagliptin, vildagliptin, and pioglitazone, very rarely used, but this can also be used and approved only. So finally, GLP-1 analog. Today's talk will be about this. GLP-1 analogs, oral or injectable. So each and every drug is unique. So in our capacity, we had to start utilizing all the agents for each and every patient accordingly, and we can keep sulfonylureas at last. So sulfonylureas specifically does not have any extra benefit. Sulfonylureas. Most of the drugs have got extra benefits. Their side effect profile is very less, except for GA intolerance in case of metformin and urinary issues in case of SGLT inhibitors. So what is this? So in 1980s and 90s, of course, as usual in North America, they can't sit idle. So they started exploring in south of USA and north of Mexico a lizard called as Gila monster. The lizard is called as Gila monster, around 1 feet in length. So it is a venomous lizard, very slow moving venomous lizard, very rarely causes death, very rarely has caused death in human beings. So from its tongue, they found out while researching, it causes hypoglycemia. Started causing hypoglycemia. Then they started extracting the venom and the saliva. They found that it contains substances which lowers the blood sugar. So in the prey, this is the predator. In the prey, it causes low sugar. So they started extracting it and found out when injected, it causes low glucose levels. So better insulin secretion. So from that, they started extracting a novel medicine, GLP-1 analog. So glucagon-like peptide receptor agonist. So what happens is these drugs. So GLP-1, there are multiple enzymes and hormones secreted from the intestine. One among them is GLP-1. What it causes is its existing insulin, it makes it work very well and reduces the insulin resistance. This is directly on the pancreas. Apart from that, this drug also works on the brain, GI tract, liver, kidney, skin, fat, everywhere. It works, and almost everything is a merit only. It causes all the beneficial effects. So such an extent, they have started exploring its use in dementia, malignancy, everywhere. Almost everywhere they started exploring its use, GLP-1 analogs. So we might see in around 5 to 10 years an explosion of GLP-1 analogs in literally every field of medicine in mankind. So what are the things available in India now? So I didn't mention one drug. It's okay. So oral Ribelces, it's called company. I have mentioned the company name. It's a disclaimer. So I have not discussed with any company to put these names. So since all are painted drugs, there are just 1 or 2 companies I am mentioning the name. Ribelces is the company name. Drug is called as semaglutide. The cost I have put because that is the first factor in India. Rest of the countries it is different. The first factor in India is nothing is covered in insurance. The patient has to pay out of pocket. So most of the companies all are reputed international brands. They have their own R&D. They themselves develop the brand. The first one is developed by Novo Nordisk, almost 120-year-old company. Even before insulin, they started developing pharmaceutical products. So 10,000 rupees per month in today's price in India, 10,000 rupees per month. So thing is, they also promote weight loss, but as endocrinologists, we don't say guarantee weight loss. We just say this drug may cause weight loss. So I know at least 5 to 10 patients per day I'm getting, because these can be only in prescription it's available. So given by the endocrinologist they have given. So whenever most of the patients try and find out they want these drugs, seeing social media for weight loss, they come to us without any comorbidities. So but we say that it is not assured, weight loss is not assured. So we say example Karan Johar, commonest celebrity you would have seen is Karan Johar, staying very lean. He is using one of these drugs, and many of Hollywood celebrities use many of these drugs for weight loss, but it is not assured. Like 23 kg, 40 kg, etc. That is outliers. Very rarely patients have those weight loss. Usually is 3 to 8 kg. The weight loss is 3 to 8 kg. Of course, they are basically diabetes drugs. They work very well for diabetes. So oral is Ribelsus, injectable is Wegovy and Ozempic. Just now it came to India. 1 month back only it came to India. 1 or 2 months back. So 15,000 rupees per month. So I just started for only one patient for weight loss. So injectable liraglutide. This has been in vogue for almost 5 to 7 years in India. Now I'm using it left and right. Daily at least 10 patients I use, 5 to 10 patients. Because it's relatively cheaper. 2,000 per month, daily once injection like insulin, and it's painless also. And another one is just came 3 months back, extremely potent drug. So tersipartide, you would have heard of the name Monjaro. Tersipartide, once a week, around 14,000 per month. It's a dual thing. It contains this GLP-1 analog plus another molecule also. So two things are available. This molecule, this one and only molecule in the world, developed by that company called as Lilly. It is the largest company in the world. So they have developed this molecule. They only started propagating insulin after 1922. So this company has come with this. So another thing would have seen, now a lot of doctors would have seen, a lot of patients would have complained, there is no more Actrapid pen fill, Mixtard pen fill. It's not available. You would have heard from this, particular physician would have heard from this word. Why? Because Novo those companies, they have left this 200, 300 rupees molecule and they have jumped to 15,000 rupees molecule. So imagine the profits they make. So that's 300 rupees extra they sold to Indian companies. You start selling these, we'll start doing these things. So what do they do? So reduce glucose at various levels. What I mean by various levels is not just pancreas, liver also, fatty liver. So it's also used in gastroenterology, fatty liver. So reduces the weight at various levels. Pancreas also reduces the fat in pancreas. So cardiac events at cerebral levels, everywhere the insulin resistance comes down, inflammation comes down. So reduce the insulin dosage, most important use for us. So now we have a lot of patients who are on 300, 400 units per day. I'm not exaggerating, really 300 units, 250 units per day. So these drugs are a boon to them, will reduce the dosage dramatically and reduce the fluctuations. Again, we hear patients having the word called fluctuations, hypoglycemia, hyperglycemia, keep on going, 533, then 50, like that they go. So these drugs reduces those fluctuations. Most important, they can be used in CKD, renal transplant, liver disease, end-stage liver disease, any patient you can use, cardiac protective. So except patients who have got pancreatic malignancy, pancreatitis, and who are vomiting, active vomiting and diarrhea, we are not supposed to use, that's all. So rest of all the individuals we can use GLP-1 analogs. So this is in type 2 diabetes and drug-induced diabetes only, not in type 1 diabetes. So problems, of course, all the good things comes with challenges. They are costly. Today's rate, they are costly. Next year it may come down. So GI adverse events, because most of them work via GI tract. Many patients can get constipation, vomiting, diarrhea, etc. So those patients you have to stop. You cannot push them to take it. So abuse potential in India, exactly what I said. There is huge abuse potential in India. Even before they were introduced in North India, particularly in Chandigarh and Delhi and Mumbai, they started smuggling it and started using for weight loss. So highly variable weight loss, it is not assured so. So a few cases, I will stop it here. These are real cases, my own patients in our hospital. So 70-year-old male CKD3 admitted for pneumonia and patient is recovering. So he was on 2GO long-acting insulin, 10 units plus twice daily mixed insulin of 15 units. Recurrent hypoglycemias. His creatinine was 1.5 to 2 and stable CKD. So what we did was we stopped all the insulins. Patient came out of hypoglycemias. Slowly started this injection liraglutide daily once. It is kidney safe. So patient was ready for giving one injection instead of 3. It's a painless. Both insulin and liraglutide are painless injections, subcutaneously given. So we started liraglutide injection. Insulin is stopped now. Requires only small pills of glycoside. That's all. Patient is doing very well. HbA1c. Remember, these patients you need not have HbA1c of 7. Throughout life, less than 8, 8.5 will suffice, and no episode of hypoglycemia. One episode of hypoglycemia can cause death in these patients. So another individual, 40-year-old female with proliferative diabetic retinopathy. The moment I say PDR, proliferative diabetic retinopathy, it is long-standing uncontrolled diabetes. So these individuals go very slow. There is no need for urgent control of sugar. But the ophthalmologist will say you have to control sugar, etc. So that day controlling of sugar is not going to be benefit of the patient. You have to control for a long period of time. So proteinuria, he has got active TB on ATT, recurrent UTI, coronary disease with a stent in the coronaries. So metformin diarrhea for her. We cannot give. She kept on suffering from metformin diarrhea. Then we stopped metformin. Recurrent UTA due to dapagliflozin, empagliflozin. But it was kept on putting by the from the cardiologist side because for cardioprotectiveness. No, the most important thing first is patient, then only statistical data. So we stopped dapagliflozin, empagliflozin. Patient is better now. No UTI. HbA1c always on 10 for the past 11 years. So she was on mixed insulin of 40 units twice daily. So we put on liraglutide, this injection liraglutide. We couldn't use metformin, we couldn't use dapagliflozin, empagliflozin. Most of the drugs we couldn't use because of side effects. So we put on liraglutide daily once, 2000 per month. Now she's requiring a minimal amount of insulin. Example 20 to 40 units in the morning and 60 to 70 units in the night. That's all. She's doing very well. HbA1c is less than 8. Everything has settled down. The TB drugs is slowly being, the course is going on and she is recovering. So 74-year-old living alone requires 300 units of insulin per day. This again extremely common scenario. Living alone, and getting insulin. Very risk of hypoglycemia, falls, fracture, head injury, so many things, death, etc. So severe diabetic neuropathy. She is not sleeping at all. Totally no sleep for her. Totally no sleep for the past 1 year. Literally sleeps 2 hours a day. That's all. Very, very poor quality of life. She has got lots of money but very poor quality of life. Requiring pregabalin of 150 per day plus duloxetine plus tramadol and so on. Increasing dose of pregabalin, tramadol. Sometimes she takes NSAID also. So again, metformin, daily diarrhea, EMPA intolerance, UTI. So we put her on Monjaro of tersipatine once a week. Now requiring only 80 units per day. She was requiring 300 units per day. It has been reduced in a month to 80 units per day. Literally the most important thing we see this with this Monjaro dual analog is very good quality of life. I have used only for 20 patients, but all of them say I feel very good, I feel strong. I don't know what's the magic is going on. So no neuropathic pain. Literally it vanished for her. Neuropathic pain. I stopped everything. Pregabalin, duloxetine, whatever, I stopped it. So if 60-year-old male, very active person, Rotarian with a moderate obesity, plays 2 hours a day, 2 meals, still the HbA1c of more than 9. Fasting above 300 always, Lantus of 40 units plus tablets. Again, DAPA, EMPA intolerance. I started on Monjaro. Another company is buying from them and selling it. The Cipla is an Indian company. What they do is they buy from them and start selling it. So 5 milligram once a week. We have stopped the Lantus only on OADs. The HbA1c is less than 8. His weight has reduced dramatically by 7 to 8 kg in 2 to 3 months. So if you see the Lantus is used only 40 units, only Lantus being used. So usually by this cases for Indians, usually the highest sugar is post breakfast sugar. After meal sugar is the highest sugar. The fasting sugar is not very high. You don't need lots of insulin for fasting sugar. So we are all basically food people. Our glucose also based on food only, not our fasting sugar. But 10% of the patients is like Caucasians. Their fasting sugar alone will increase. Postprandial will not increase. So we have 10% of the patients where we use only glargine, long-acting insulin. We don't need a short-acting insulin. So these patients also, this GLP analogs will be pretty much useful. So this individual, again, young coronary disease, 34-year-old male with a PTCA done. Again, metformin, acidity, diarrhea, DAPA, EMPA, severe balanitis. So we put on oral Ribelces. He was about to require insulin. We just put on oral Ribelces. Now doing very well. Weight loss about 3 to 5 kg. And effort tolerance also improves. He had NIHA class grade 2 or 3 dyspnea. It improved very well. OSA also actually improves, but not too much of CPAP, but it helps in improving obstructive sleep apnea. So 86-year-old female, type 2 diabetes, lives alone, HbA1c of 9 on multiple OADs. So she was started on insulin twice daily. Again, hypoglycemia, 2 falls, 1 fracture, operated. So we put on patient Ribelces 7 milligram per day. No, there was no requirement for insulin. She's on only dapagliflozin plus this drug, and HbA1c is doing very well, less than 7, less than 8, and her quality of life is good. So thank you. I'll stop it here, sir.
We are well aware hypoglycemia causes brain damage. What is the pathogenesis of myocardial infarction
Arrhythmias.
in hypoglycemia?
Causes excessive cortisol response, sir. So once hypoglycemia is there, immediately there's a surge of epinephrine, noradrenaline, cortisol, which will cause BF in VT, sir. It will cause ventricular arrhythmias. And also excess stress on the heart, already damaged heart, not normal heart, already damaged heart. Every episode of hypoglycemia will cause some damage on the coronaries. So each and every surge of cortisol is responsible for inflammation of the heart, inflammation of the coronaries. That is the reason, sir.
What is the expansion for GLP?
So glucagon-like peptide, sir.
Secreted by
Intestine, sir. It
which
is also
part
a
of the
hormone,
intestine?
sir.
Jejunum or
Jejunum, sir. Jejunum. Duodenum, sir. Sorry, duodenum. Basically, from enterochromaffin cells, there are a lot of enzymes in the duodenum. One of them is GLP-1, sir.
So you don't use for those patients who underwent either stomach surgery or proximity or duodenal surgery.
So we can, sir. Stomach surgery is almost a bariatric surgery. Even if you are done for a malignancy, say a growth in the stomach, it almost becomes like a bariatric surgery for them. So what we often say is, if you do any GA surgeries, the glucose will dramatically come down.
The question is, if you don't have duodenum, you don't use these drugs.
Oh, of course, we cannot use these drugs, sir. But there will be no necessity to use these drugs, sir. And apart from this, they also have the enzymes are also secreted at various levels in the body.
Yeah, that's what I was.
In the central nervous system also.
So you have non-duodenal sources for GLP.
Yes,
so
common sources duodenal.
Yes. My question was
Yeah,
about to
okay,
follow
yes.
that. So any more questions? No.
Sir, okay. Last, I should have mentioned long-term effects. It's a since it is in vogue for only for the past 5 years, we need long-term to say that, sir. At least 15 to 20 years later, maybe we may. Your question may be right. There may be long-term effects. So now, in the advent of research era and internet, continuously being monitored for a safety profile, particularly malignancy profile, continuously being monitored, sir. As of now, there are no long-term effects, but the duration lifespan of this is only 5 years. Only for the past decade we are using across the globe.
So that's the last question.
As monotherapy, usually they don't cause hypoglycemias. So these drugs and that SGLT inhibitors work only when the glucose is high. The glucose is normal, they will not work for reducing the glucose level. So as monotherapy, they don't cause hypoglycemia. But if you use as add-on to say insulin or sulfonylureas, so those drugs will become very potent and will cause hypoglycemia. So that's why we reduce the insulin dosage and sulfonylurea dosage.
Thank you. So those are indirectly acting drugs,
yes,
by stimulating. Thank you, Krishna, for your wonderful talk. And over to Dr. Siddartha for his presentation on neurocritical monitoring at NICU. Dr. Siddartha.
Good morning, everyone. So, jump in spectrum now from diabetes to newborn care. So, and then I'm going to really focus on the brain part today, because usually when we say ICU, we really think of heart and lungs. So we don't think too much about how to protect the brain, especially in the NICU, where the brain is a developing organ, still not mature. So whatever we do at this age can affect the brain growth and development. So there is a new focus on how to do this better for newborns in the ICU by protecting their brain so that they achieve their full potential. So we'll be talking about advanced neurocritical monitoring. Treatment part and bundle treatments is not part of this talk. It will take too long. So we'll just focus on new monitoring that we do. So there are two main kinds of babies who have at risk for brain injury. One is extreme preterms. That means babies are born before 28 weeks of life. So what we have done in the NICU, if you see the graph down, is there is a lot of good survival now. Recently, in the last 10 to 20 years, our survival rates have gone up, especially more than 26 weeks. We survive almost 80 to 90% of babies go home. But our challenge has been that in the smallest group, where somewhere between 24 to 27, we still do not have enough survival as well as good brain development at this age. So we have problems with babies who are born at this small borderline viability. So our challenge now is to make them better, have better long-term outcomes, that they are intelligent, they don't have CP, they don't have motor outcomes. So that's one. And next is hypoxic ischemic encephalopathy. Babies who are born asphyxiated at term. It's a huge global burden. So there are around 700,000 births every year who are asphyxiated, much more in developing country like us. So we have a huge burden of these babies. So they are, even though we have a new treatment called hypothermia, we do total body cooling for babies who are asphyxiated to decrease the brain injury. We still have around 30 to 50% who will have long-term bad outcomes even in this group. So the whole research now is to see how to better their monitoring and treatments so that this number can come down. So this is how a new neuro ICU would look, neuro NICU. So where the baby is all surrounded with different new gadgets, where we monitor them better. So this will talk about these things. It's called an amplitude integrated EEG. This is the NIRS tool, it's a near infrared spectrometry. This is a cooling device that we have in our NICU as well. We do total body cooling. And this is the PCO2 monitor. So the baby is surrounded by a multitude of monitors and we get a lot of data. So, but all importantly, we should not forget that there's a baby there, and our clinical exam is probably the most important stuff. So this is now called neonatal neurocritical care. And how do we do it is whether you have a dedicated space or as a separate unit from the NICU, but that is not possible in most of the NICUs unless they are very large and teaching hospitals. So what we can do is have a dedicated team which provides the care in the same unit. So you have a neonatologist, you have a pediatric neurologist, the physiologists are there, and then nurses who are trained in the NICU care with neurospecialty. So all these and physiotherapists and occupational therapists, all of them are dedicated to provide a neuro NICU care. So what is this neuro NICU will try to do is we'll give them specialized training, get them better equipment, and have multidisciplinary collaboration to improve outcomes. How do they improve? So you have enhanced neuromonitoring leads to early detection of problems, so you can treat them better. You have standardized protocols. You have evidence-based medicine protocols, so they optimize neuroprotection for HIE, IVH, and extreme prematurity. And then because there is a collaborative environment, there is a comprehensive care. So specialists are more involved. They come and do their. It's not just saying that it is only an NICU job. So this supposedly reduces the brain health, complications and improves the brain health. So what all do we do in neurocritical monitoring? So main thing we are going to talk about three stuff today is amplitude integrated EEG, a continuous EEG, and an NIRS tool. So first, coming to amplitude integrated EEG. See, generally the conventional EEG will have a lot of, at least minimum of 8 electrodes, and then it goes up to 20 electrodes on the brain. So here what we generally use in an amplitude EEG is just about 2 to 4 electrodes in these places, C3 or C4. This is the central one, and the parietal P3, P4, usually 2 leads or 4 at best. So this will give you some data which is not from the total brain, but these are the areas where the newborn brain usually gets affected. So we take EEG data from these leads, and then what we do, this is the raw EEG data. So then this EEG has number of waves which go up and down. The amplitude integrated will remove the outliers. The highest amplitude and lowest amplitude is removed. They are all rectified. That means any negative wave becomes positive. They are smoothened for any other artifacts, and then its main thing is compressed. That means 1 millimeter of this data will have 1 minute of EEG data. So that means if you have an EEG page of 1 day, it will show full that day's EEG data in a compressed format in a logarithmic scale. So what it will do is the EEG won't look like this. It will look like this way. So, and if you put a cursor in one of the places, it will reveal the EEG, the conventional EEG waveform on top. So what we are getting is a compressed data in a very small time, in one page you get a lot of time frame involved, so that is one advantage. So what is the advantage of this is that there are some patterns. This is how we read an EEG, is to see how patterns are differing and what each patterns will tell you. So even bedside nurse can detect seizures, and therefore there is a timely intervention that is possible. So how do you read this EEG is, you see how is the bandwidth, what is the upper voltage, what is the lower voltage, how is the whether there is the amplitude is very flat, it will look like a flat isoelectric line. If the upper margin is going beyond normal, it will reveal a seizure. So the few patterns that we can see in EEG is, this is the normal wave in a normal term baby who is active, has no encephalopathy. There is a good amplitude. The lower border itself is more than 5. The upper border is more than 10. So it's actually now here, this is between 15 to, more than, it's going up to 50 also. Whereas during sleep, the lower amplitude will fall. So the bandwidth will look like it is big. So there is a change. So awake form, it is a narrow bandwidth, but it's up. And the sleep, it will be a wide one. So this is an alternating pattern. This is a normal term baby, you will see an EEG like this. Whereas if it's a mildly affected baby, or baby who has a lot of is slightly premature, it's called a discontinuous wave pattern, where both the lower border is slightly just about 5 or slightly less, the upper border is still more than 10. So but it will not have a sleep wake cycle change. So this is a discontinuous but still normal voltage. Here you see a lower margin which is below 5, and most of the activity is in the lower margin. So, and then there are short bursts that go up and down. So this is a burst suppression, and then this is in low voltage with no bursts, there are no bursts. So this is mostly low voltage, and these two are quite abnormal. So babies encephalopathic or extreme preterm, having hemorrhage in the brain, you can see stuff like this. And this is a flat trace where there is absolutely no brain activity. So more or less what you see in a conventional EEG, but this is easy to interpret for bedside clinicians and nurses, so that you can prognosticate better whether you treat at the same time. So this is again the same thing. This is a term baby, you will see is preterm baby, where it's like a waveform, and the lower margin is less than 5. As they mature, the lower margin goes up, so it's more than 5 here. And this is a term baby, it's all lower margin is almost near 10, and they have a spindle shape. This is sleep wake cycle. This is the difference between a preterm and a term brain maturation. So what is the use of this AEGs? Mainly one thing is prognostication. So if you see this kind of normal background activity, even in a baby who is asphyxiated, you can tell them that it's a good prognosis. But if you see that you have started, TH means therapeutic hypothermia, and you've started cooling these babies, and the baby's background activity doesn't normalize by 48 hours, it's a bad prognosis. So you can tell them that this baby is going to have some kind of problems in future, they should be ready for it. So in addition to using MRA data, AEG data will help you prognosticate better. The other thing is to use for detection of seizures. So what happens is, there is many of the time it's very difficult to pick up clinical seizures in a newborn, because just even sucking, repeated cycling movements, chewing, blinking of eyes, all this can be subtle seizures. So sometimes we overtreat the seizures thinking the normal activity is a seizure, depending on the clinical basis. So if you use AEG, what they have seen is there's an improved detection. Sometimes we miss, so we detect them better. We treat them better. So there's a rapid treatment. So you're appropriately treating the seizure fast. Because you're treating the seizure fast, your status is less, and then there's reduced cumulative doses of anti-seizure medications. And we have seen that we actually use less anti-seizure medications if we use an AEG rather than the opposite. So how does a seizure look on AEG is, this is a normal waveform that we have seen. Here if you see, there's an abrupt increase in the amplitude. You can see a spike there. So all these are seizures. And if this is status, there's a continuous uplift of the lower border and whole amplitude. So this is a status epilepticus, and these are very easy to pick up even for nursing with minimal training. But there is some caveats to remember. Is it's because it is only coming from a few leads, you don't pick up brain activity from the entire area. So if the seizures are originating from frontal or occipital, you don't pick them up as well. And low voltage are usually missed, and because it is compressing data, brief seizures will be missed. But about 50%, even for bedside junior doctors or nurses, 50% pick them up quite well. If you have a corresponding conventional EEG attached to it, your pickup rate of seizures goes up to 70 to 80% as well. This is a continuous EEG as opposed to an amplitude integrated. You have to put a lot of leads on a small baby. It's cumbersome. You need a neurologist to interpret this. So that is why we went to use an AEG better. But there is a place for using conventional EEG as well. So if you detect seizures, you have to use a conventional EEG for at least 24 hours after the last electrical seizure. And whoever is at risk for seizures, it's better to use a conventional EEG as well with a video, so that you are this is more sensitive and specific. So the other one is a near infrared spectrometry. So I don't know how much of we use in the adult population, but this is something that is coming up in the newborn, but it's been on the bench side for a long time. Just in the last 2-3 years, there are a lot of clinical studies as well. So this gives you a tissue oxygenation index instead of just the pulse oximetry. So this is how it typically looks like a pulse oximeter, and this is where it gives the tissue oxygen. And there are a few other things that we will not go in, but typically a normal tissue oxygenation will be around 65 to 80%. Okay. So what does it do? You put a probe like this on the forehead to measure the brain tissue oxygenation. Okay, and then the monitor will deliver different wavelength lights, and depending on how the different wavelengths are absorbed, it calculates what is the oxygenated hemoglobin, what is the deoxygenated hemoglobin, and then it will give you a tissue oxygen index. So it's basically a mixed oxygenation, not just arterial. So that's why it is less than the arterial value. There are different reference ranges. You can see that about after birth, about at 15 minutes, it reaches 72. So that's, and preterm babies also, it might take a slightly longer time to reach that level, but it's about 60 to 80 is the normal tissue oxygenation. See, just an easy chart to remember. If cranial SATs are less than 60, they are abnormal, but if they are less than 40, it is definitely a danger zone. We need to intervene to improve oxygenation of the brain. And again, if a difference of between 10% between cerebral and renal SATs, then we also need to improve. So there's different tissues can be measured using NIRS oxygenation. Brain, kidney, and then gut is coming up. So again, if the levels are more than 95, if it's very high tissue oxygenation, also it's wrong, because the brain is not able to extract any oxygen. So it is absolutely non-functioning brain. So that is also a very bad prognostication. So decreased tissue oxygenation can be suggestive of either decreased oxygen or decreased blood flow. So if you have anemia, DSATs, hypotension, high intrathoracic pressures which are preventing venous return, CO2s which are low, or baby is having high energy requirement because of seizures, pain, fever, all this can be corrected to improve the oxygenation. So increased cranial SATs is either you are giving too much oxygen, flow changes, CO2 which is high, low sugars, babies over sedated, or completely having severe brain injury. So all these are factors which can get a more detailed way of measuring brain oxygenation, not just your pulse oximetry, which might not give the correct picture of how brain is actually getting oxygen. So what happens in neonatal encephalopathy is initially there is an increase in this tissue oxygen, decrease because of hypoxia or ischemia, and then when the reperfusion starts, this tissue oxygen will go up, but it should not go up to a very high level. So if you see, this is the day 2 data of a HIE baby who is severely asphyxiated. The day 2 AEG is this is low voltage, right? So the day 4 is, as we have seen, this is a burst suppression pattern. But what happened in the NIRS is initially there's a drop at 24 hours, and after that it's been on the higher side. So you can see it's more than 90 here. So as you've seen, the brain is not at all extracting any oxygen, so your tissue oxygen is gone up. So this is a very bad prognosis, and if you see the ADC image on the MRI, there is a lot of injury of the in the brain, ischemic injury. Whereas this is a moderately encephalopathic baby, there is a discontinuous EEG pattern, and which changes to a normal continuous sleep-wake cycle pattern by day 4, and NIRS also will give you a similar image, where initially it is between 60 to 70, but then it is initially it dropped to 50, and then it's plateaued between 60 to 70, which is a normal SAT, and the MRI is not that bad. So main idea is that there's a multimodal monitoring that is involved. So you want to do everything together. You collect all the data, interpret your data, make sure you're not missing anything, and you give a targeted, precise treatment to improve outcomes. So summary is, definitely for neonatal encephalopathy in term patients, you need to have AEG, especially when you do hypothermia cooling. But AEG is not a criteria to take them into cooling. So it is only to help you guide your management decisions. And if you think the baby is very bad, we need to have a continuous EEG monitoring as well. Prognostication, you take all three together, and if you have normalized AEG patterns by 48 hours, it's a good prognosis. So same thing for extreme prematurity that we have already talked about. So I think I'll stop with this. The call to action is that we should have a neuro NICU. We should have all these machines with us. So we need AEG and we need NIRS. We already have a cooling machine. So to better treat all these babies, we would like to upgrade this to so request management to help us build this NICU. Yeah. Thank you. I'll take questions.
Thank you, Siddartha, for the wonderful presentation. Suja, you can note this right now. So this NIRS as well as the AEG country that is given for the any questions? Cooling. Do you apply cooling right above or
Huh?
They do very good. If you're having refractory bradycardia, that means not stop. But that is not.
This was cardiac. And as a teacher, our regular teaching is important parts we can do it with babies. Hypothermia, aspiration, those things.
Yes, but this is a natural decrease in temperature in a controlled environment. So we don't go right from 37 30 degrees. We go every half an hour, decrease 0.5 so that we are reaching the target cooling temperature over a few hours. But this baby is already continuously being monitored. We check their labs continuously, electrolytes, acid base, everything is done. And then we cool for 3 days. And then we start rewarming. But usually there is no cardiac arrest as such, but there can be some babies who develop severe pulmonary hypertension because of hypothermia, and then we might not be able to continue cooling. Same thing, they can have bleeding issues, so then we have to stop. Right now, not in the unit. So we get from the neurology department, and then we do EEGs. Like it's a status. With cooling. Yeah, cooling, seizures are expected in hypoxia. So then we have, because in asphyxia, right? So whether it's because of the asphyxia or is it because of cooling, we have to take a decision. But mostly because it's already an affected brain, and we only use cooling in moderate to severe HIE. So we continue cooling. Yes, antiepileptics if required. Yeah. But we want to avoid the classical antiepileptics like phenobarbital, phenytoin, for at least as a first-line drug, which is changing now, because they all cause neuronal apoptosis. Because they are growing brains, they cause cell death, and that is why. So we, in top of hypoxic injury, if you give phenobarb, it will stop the seizure, but there is also a risk that they cause apoptosis, and that's an additional brain injury. So right now, Levipil, and we're going that way as first line, but sometimes required to use.
with HI, yeah. Like cord blood ABG is to look at the bicarb status, acid status, and it's one of the inclusion criteria for HI, in addition to how the baby is behaving clinically, but not a correlation with NIRS. But the cord blood gas is to take the babies into treatment, whether requires schooling or not. This would be the next step to follow. So that's the first identification. Like which way, ma'am? These are not still become standard of care. Yeah. NIRS at least is not standard of care. Cooling and AEG have become in most NICUs, but not NIRS yet.
Yes, you told me 15 minutes, sir. I hope I finish within the time. So good morning, one and all. Today I'm just going to show some few interesting cases that we saw in our NICU in the last 6 to 7 months. Usually our department is a very peaceful department. We don't have many differential diagnoses. We treat HMD, BPD, we treat jaundice. We even TS postgraduates that they have stamp pad notes like baby is feeding well, past urine and stools, no jaundice. That's what they write. But occasionally, once in a while, we get the case like you see a report and then you wake up in the middle of the night and you see why is it like that. So I'm sharing just few cases like that. If time permits, we can follow up with discussions. So the first case is baby of V. This is a well-termed girl baby. This is an outborn baby born to a primigravida mother by normal vaginal delivery. So there was no asphyxia or any risk factors, no other family history except one IUD in a distant family member. They were referred from another hospital in Coimbatore with main complaints of neonatal seizures from day 3, multifocal, not refractory. They were actually responding to the seizures, were responding to anti-epileptic medications. Sorry, I missed to fill them. The baby was an appropriate for gestational age. She weighed 2.9 kilos. HC, length, head shape, everything was normal. Neurological examination after the seizure management, tone and activity was slightly decreased. DTRs were normal. No asymmetry or paucity of movements. Head to toe examination was normal, except that we noticed the slight lesions. Sometimes we see this skin peeling even in post-dated babies. So except for this minute skin lesions, and here we see a varicose lesion also, except for that there was no actual clinical examination findings for this baby. So we get neonatal seizures very often in our NICU. Most of them is idiopathic. So we treated with antiepileptics. Our routine sepsis screen, blood investigations, electrolytes, everything was normal. The baby became neurologically normal after 48 hours. We got an MRI done which showed multiple infarcts. So there are infarcts in it was not confining to any one vascular aspect. So there was parietal, parieto-occipital, temporal, and even occipital infarcts, minute infarcts, it looked like a microvasculopathy, which is one of the commonest causes of seizures in a neonate. We sent the baby home on antiepileptics. On day 12 they came back telling they bathed the baby, they had used some emollients and everything, and suddenly the baby developed eczema. At the time of admission, the baby had mild respiratory distress, oxygen requirement, and we started on nasal sprong. We got an X-ray, nothing was there. We got an echo and it showed pulmonary hypertension. And these were the skin lesions then. It was at this time that our antennas were going up. Lot of varicose lesions. We are seeing bulle lesions which were crusting also, predominantly on the extremities. So they were following a linear pattern also. This was when we started thinking that this is something else. So we had a girl baby born well without any risk factors, unexplained multifocal cerebral lesions, progressive eczema, and new onset pulmonary hypertension, hematological and metabolic investigations. Because of the stroke, we had also done metabolic profile and everything, procoagulant workup, everything was normal. Then as we were waiting for our answers and reports, the disease evolved itself. This is on day 20 of life when we are seeing this hyperpigmented keratotic plaques, linear pattern, and severe eczema, different stages of lesions. We see like there are plaques, then we see this hyperkeratotic plaques. So with this clinical progression, we went ahead with the skin biopsy, which also showed eosinophilic spongiosis with intraepidermal blister formation, which is very classical of the genetic condition named as incontinentia pigmenti. Now, incontinentia pigmenti, it is a genetic disorder, very rare, almost 0.7 in 100,000 live births. It affects something called as a IKBKG gene. So it affects the epidermal structures and the neuroectodermal structures. That is why they also cause vasculopathy. That's why the stroke, the pulmonary hypertension, and they actually have very classical 4 stage of skin lesions. First is the bulle lesions, then the verrucous lesion, then the hyperpigmented voles, and then the hypopigmented scars which form. We were able to, the only a curious point in this case is within a period of 15 days, we were able to see all stages of this disease in the newborn baby itself. Usually it starts manifesting in the pediatric age group. This was a very early presentation comprising of all the components of incontinentia pigmenti. Let's move on to the second case, which is another totally different place. This is baby of A, born to a second gravida mother, no significant family history. Fetal anomaly scan showed absent ductus venosus. Usually absent ductus venosus doesn't have any clinical significance except that it is a soft marker. We have to look for other chromosomal anomalies and malformations. So this mother had underwent an NIPT, which was normal. The baby was born by normal vaginal delivery. It was a boy baby. Weight was 3.4 kg, appropriate for birth. There was no dysmorphism. There was some delayed transmission. The baby had some TTN, so we took to NICU. And because of the absent ductus venosus, we wanted to look for cardiac malformations. We did an echo, which showed physiological pulmonary hypertension, nothing abnormal. Breastfed, and then we shifted back to mother's side. We were planning for discharge and our routine, the stamp padded nose, we got it bilirubin done at 72 hours of life, and then when the surprise came, the conjugated fraction was around 15.8 milligram DL. So in NICUs, when we have cholestasis, we have a routine protocol. So we did the LFT. It was more than of hepatitis than an obstructive jaundice. SGPT, OT were elevated. There was not much of coagulation abnormalities. We did all our IEM workups, galactosemia, thyroid function, inborn errors of metabolism, everything was normal. Ultrasound abdomen was normal, stool color was normal, and then we started worrying why this baby is having so much of hepatitis and cholestasis. After coming to NICU, the baby again had oxygen requirement. So X-ray was normal. Echo we repeated, which again showed moderate to severe PPHN, which was increasing from what it was on day 1. So that's when our answer came in the form of our pediatric cardiologist. Dr. Dev Prasad walked in while doing an echo, and he gave us a clue that but probably are dealing with an Abernethy malformation. Probably you should go ahead with a CT abdomen. I was not able to get a good image of this. So Abernethy malformation is a congenital portosystemic shunt. So this is a CT contrast. So there will be a connection between the portal vein and the IVC. So it will be almost like a hepatopulmonary syndrome where the metabolites will be directly getting connected, transferred to the systemic circulation without going through the river. So here we were seeing communication between the portal vein. It was a side-to-side anastomosis between the portal vein and the inferior vena cava directly. So CT abdomen gave us a conclusion as Abernethy malformation. Only thing was, this is again a very early manifestation. Usually the median age of presentation is 6 to 12 years. When after 12 years they present with pulmonary hypertension. Here we have a newborn who is 3 days old with severe hepatitis with pulmonary hypertension requiring oxygen. Slowly with medical management we were able to wean off the oxygen. The baby is now at home. The plan is, this is a type 2 Abernethy malformation. So if the baby becomes symptomatic at any point of time, we are planning to do a catheter occlusion of the anastomosis, because we were able to make out the point of shunt. We will be planning for a catheter occlusion. If that is not possible, this baby might land up with liver transplantation. So we were having a type 2 of Abernethy malformations. Let's not go into the details of the types of it. So now this is case 3. This is baby of Y, outborn boy baby, second gravida mother, 36 weeks of gestation, uncomplicated pregnancy. Actually, the mother was admitted in the outside hospital with complaints of decreased fetal movements at 36 weeks, and she underwent emergency LSES. But the curious thing was, she was telling over the past 2 weeks the movements were decreasing like little by little. It was not an acute onset absent fetal movements. Immediate examination after the delivery by the pediatrician there, she found out that the lower limb was hypoplastic. They were looking small to the chubby baby with contractions. The knee and the hips, they were not able to extend and absent movements. Whenever we see a baby like this, we usually think of caudal regression syndrome. So the pediatrician there labeled it as caudal regression syndrome and referred to it as for further neuroimaging and management. So this is a baby printed here with permissions. You see a very chubby, handsome male baby boy, but you see the limbs very hypoplastic and he was not moving it at all. Apart from that, there were no malformations in the initial period. On examination, there was one small bluish ecchymotic patch in the abdomen. Blood investigation showed the platelet count to be thrombocytopenic 73,000 and PT, APTT were all elevated. There was a small ecchymotic patch. The baby is paraplegic and we had this report. Immediately we went ahead with an MRI brain and spine which showed acute parenchymal hemorrhage in the front photovarietal matter, spinal subarachnoid hemorrhage which was actually causing ischemia around the spinal nerve roots, and more importantly there was a bilateral orbital retinal detachment with hematoma. So this is showing the orbital retinal. All this was blood which was getting collected within the orbits, and this was the myelolipoma, and this is a track of blood which is seen in the lower part of the spinal cord. So we had a child with coagulopathy who's bleeding. So the first few 1 or 2 weeks we were thinking this is a coagulopathic disorder, this is a bleeding disorder. The baby was getting corrected with FFP, but once you stop FFP after 48 hours, again these blue ecchymotic patches were developing. So we went ahead because we had already given blood products. You can't do any other hematological workup. So we went ahead with the genetic testing, which showed this to be a severe case of protein C deficiency. So what was rare in this case was that protein C usually presents with coagulation, thrombosis. But here the thrombosis was so severe and it happened intrauterine that the fetus had gone into DEC in utero itself. That is why the intracranial hemorrhages, that is why the subarachnoid hemorrhages, and that is why the retinal hemorrhages. The parents is not concerned for further care because of the paraplegia, and the child was bilaterally blind. So they opted to give compassionate care for the baby, and they went to our Coimbatore Medical College Hospital. Now this is case 4, outborn baby born in Erode, primigravida mother, IVF conception, term female baby, did not cry at birth, PPV and intubated. So the pediatrician there was treating it like a birth asphyxia. So mother had come with decreased fetal movements, emergency section, and baby did not cry at birth. He had intubated and given PPV for the baby. She was in an NICU in Erode for almost 20 days. They were worried about extubation failure. Every time they were extubating, the baby was aspirating, the baby was not able to breathe, the baby was not gaining weight, there was severe stridor, severe gastroesophageal reflux. They thought it was all a case of hypoxic ischemic encephalopathy with sequelae. They got an MRI brain which did not give much, did not contribute to the diagnosis. There were mild periventricular hypointensities. They initially treated as birth asphyxia, I mentioned, and after 20-25 days, they had a doubt that this baby might be having something genetic like a myopathy, and then they referred to us for further evaluation. So when the baby came to us, she had severe failure to thrive. She was born at 3.6 and now she was just 2.8 kilos. Pooling of secretions, hypotonia, minimal contractions against knee and elbow joints. The baby was not able to cry at all. It was a very low volume cry and depressed deep tendon reflexes. We managed on NIVs, but the main concern was GER. We were not able to feed the baby at all. She had to be re-intubated twice in our NICU itself because she was getting these aspiration episodes. Even our first diagnosis was myopathy. The only contradicting point was the contractions which were developing very early in life. This was the chest X-ray which was showing some aspiration-like patches, but they proved to be hypoplastic also. They were not opening at all. This white patch in the right lung was always there in the sequential X-rays. I hope the video plays. So this we did a video laryngoscope. Just while before intubating, we wanted to document what is happening to the baby. So this is a orogastric tube. While passing the video laryngoscope, you'll feel that the uvula is not at all moving. There is so much of aspiration. This is a glottis and you see milk coming in. This is where we are planning for intubation for this baby. So much of milk coming out. And if the video is clear, you will feel that the vocal cords are also not moving at all. The vocal cords were not moving. The baby was trying to breathe, the baby was trying to declinate, but the uvula is not moving and the vocal cords had no movement at all. This is another video where I just wanted to show that again the glottic folds were not moving at all. No opening, no closing, they were just staying like that. So this gave us a clue that a baby is hypotonic, floppy, and there is cranial neuropathy. We thought more than a myopathy, we are dealing with a congenital neuropathic disorder. So again, we went ahead with the genetic testing. This is a boon for all NICU sick neonates. So we got a rapid sequencing done and we were able to label this as a congenital hypomyopathic neuropathy type 3. So, congenital hypomyelinating neuropathy type 3, this is type 3, is actually a very, very, very rare disorder where a baby will have cranial neuropathies predominantly followed by contractions in the extremities. So, they will be having severe failure to thrive and survival is very, very difficult, and we lost this baby because of ventilation failure. Now, this is the last case for the day. Baby of V, born to a second gravida mother, term boy baby, birth weight is 3.5 kg, elective LSCS. So he was well at home, exclusively breastfed, discharged roamed on day 3. The mother herself was a nurse in another private hospital in Coimbatore. On day 9, the mother after a feed had placed baby in a cradle. Sudden frothing from mouth and unresponsiveness. When she went, the baby was frothing from the mouth and unresponsive. So whenever we see the baby, we start blaming the mother. You did not burp the baby has aspirated, that is why the baby has collapsed. Even when a baby has come to such a state in our NICU or emergency, we tell query aspiration is what we label. The baby was received in a nearby hospital. The baby was found to be gasping. He was intubated. While intubating, this is also one common thing when milk was coming from the trachea, so this baby has aspirated. He required CPR for 3 minutes, referred to us within 2 hours of the event. We put the baby on ventilator. He was having minimal spontaneous breaths, required 100% oxygen. He was hypotensive, but after some fluid resuscitation, we were able to improve the baby. Severely pale, neurologically pupils were sluggishly reacting to light. Initially, we thought that it was because of the resuscitation that he is in a comatose stage. There were no spontaneous movements in the lower limb and some flicker in the upper limbs. We got the investigations done. So that investigation gave us a clue. So he was anemic, so he was bleeding somewhere. And if you see the PT and INR, the PT was normal, but the APTT in isolation was elevated. Apart from that, most of the reports were normal for this child. So this is a clinical course. By 2 hours of admission, we found that he was going into more and more deeper coma. His AF was bulging and he was becoming more pale. Ultrasound cranium showed hemorrhage in the medullary area. We went at the urgent CT brain. Neurosurgery preparation and counseling was done because the baby had a medullary hemorrhage. By the time we got the blood reports, that's why we thought APTT is prolonged. So we started transfusing blood product also. Family did not consent for surgery because of the outcomes. It was a medullary hemorrhage and he was already comatose for almost 6 hours now. By 12 hours, we decided to send a genetic testing for them. So this is a hemorrhage which is in the posterior fossa. So this genetic workup showed that this to be a case of hemophilia A. Though this is a novel mutation, it was a case of hemophilia A. So what was new in our case was that the age of presentation. Usually in hemophilia, the age of presentation is usually 3 months, and cranial bleedings will start happening only by 7 months when the baby starts crawling, tries to walk or so. This was a newborn baby. The CT did not show any features of trauma, but we don't know whether they were rocking the cradle or anything. The family was devastated, but at least we were able to counsel them. They had another female child. We were able to counsel them for the genetic screening and follow-up also. So with these 5 cases, our learning point was that we should always have our eyes open for any minute changes in the report. With that APTT, we decided that we have to go for a genetic testing for this baby. Not all things are horses. We might have some rare zebras also in our group. So only when our brains know, our eyes will be able to see. And I thank our entire NICU team, our postgraduates who have been, and the other teams like neurosurgery, Dr. Dev Prasad, who have been in played a very important role in managing these cases. Thank you.
Presentations. Few comments. This aberrancy we see in adult also. Aberrancy
yeah,
malformation. That is one of the important cause for extra cardiac shunt lesion presenting with a central cyanosis with clubbing.
yes.
So if you have a no shunt, clubbing, central cyanosis, the first thing it should go to the liver to see this. We have couple of aberrancy also in adult population. They present with isolated pulmonary hypertension. So even the recent last national best award went to this aberrancy malformation.
Yeah, Dr. Dev Prasad had seen one, a 12-year-old child, because that's why when we called him, he immediately said, you look for aberrancy malformation. Being pure neonatologist, I have practically never seen an aberrancy presenting with pulmonary hypertension in a neonatal period.
But we have it. That is one of the cause for unexplained pulmonary hypertension. We have a couple of patients. One, number two, this protein. See, I don't know for what reason we see. This protein C always combined with the protein S deficiency present with thrombosis in adult.
Yes.
For example, so it is not an isolation. It is usually we see protein C combined with the protein S.
Yes.
When they present with thrombosis.
This is congenital.
Yeah, no, but we don't work up for congenital because for us, for the treatment strategies, we don't go beyond this. Whenever patient comes with thrombus, for example, pulmonary embolism, we always take sample first before giving a heparin because it reduces. Heparin reduces protein C, protein S level. So the level which is taken, the sample which is taken after heparin administration can be falsely low on the other side. So we don't go beyond that because all these patients require a lifelong oral anticoagulation. So we don't test beyond that. So that's it. And what happened to that hemophilia patient afterward?
We lost a child. They did not want care because of the medullary hemorrhage.
So I thought I was, since it's a reversible cause, so can be treated. I thought so. She might be.
Yeah, we were planning for surgery, but because of the medullary ischemia, they didn't want to proceed with the surgery.
We really congratulate you.
Thank you, sir.
Whether it is all the 5 zebras or tigers, we remember what we have read in our clinical methods in surgery by Das.
Yes.
So we have to be updated, and eyes will not
Do not see what the mind.
What the mind does not know.
Yes. Eyes will not see what mind does not know.
Yes. Thank you.
Thank you, sir.